Hi there. My name is Geraldine Strathdee, and I'm the chair of this Challenging Behaviour series. So I chair a panel of wonderful people who have courageously come to put forward views that everybody wants to hear, be challenged with questions, and we can debate among ourselves the standing items of today. We started this series because young clinicians, professionals working in services, patients, families wanted a safe space where they could debate some of the ethical and the issues they find challenging today. So we've had topics like, is restrictive practice really something we should be doing anymore in mental health? Why are we still training people in it if we don't want to do it? Medication, does it work for everybody? Are we monitoring it well? Does everybody need to be on it for life? We've had young clinicians saying, I don't understand why we have to have different standards at every single part of the services I work in. Can somebody help me? We've heard a lot from young professionals of color and young professionals who are not of color, talking about white privilege, talking about what it feels like when you actually have to go and manage difficult situations for people who you grew up with on the estate that you grew up in, and they're in seclusion. And there's a whole lot of issues about assessment and the length of time people are there. So what we wanted is to create a safe, open debate space. My principle in life has always been that if you don't talk about something, it bubbles up and it blows. And I suppose my learning from that started at the age of 10, having grown up in the very troubled, divided communities of Northern Ireland, where even as a 10-year-old, you could sense the bubble and the conflict in society that having one community disadvantaged from another was giving. So to me, if you can't find a solution-focused way to share open views and find solutions, you're probably not going to be able to solve it, and sooner or later it will come back to hit you. So our subject today is the wonderful world of digital. Love it or hate it, beauty or beast, as we've called it, it's raised great potential things we can do, but it has also raised great challenges. So I am thrilled to bits to welcome four, and I would actually say friends, as well as experts, to talk about the different issues of today, the world of digital, the world of sharing information, the impact on practice, the impact on our world, the impact on wider mental health. And I'm going to start today with a very, very courageous young leader, Nicola Byrne. Nicola blitzed loads of, I would say, challenges in setting up our webinar, our internet at the Maudsley. I've never seen anybody so patient and hearing from people using the system what needed to change, finding solutions as a way forward. And so it was actually not a surprise to me when she had the amazing courage to apply for and be successful in achieving the role of National Data Guardian in England, taking over, I would say, from another female psychiatrist. Very unusual to have a psychiatrist honoured to be our National Data Guardian in that way. So Nicola, welcome. Tell us what your challenges have been in the new role and how you respond to people who say, shouldn't it be called the National Data Sharing Guardian, not the National Data Protection legislation? What's the balance? How can we get it right so people get the information they want and it's shared with who they want it shared with for benefit, but not in a breach of confidentiality?
Thank you, Geraldine. Thank you for that lovely introduction. And the word I hung on to at the very beginning there was young. That was so I suppose a couple of things. You asked about the challenges so far. And what would I say to people that think it should be National Sharing Guardian or something along those lines? And I suppose the role of the National Data Guardian is to advise and challenge the health and care system to ensure that people's confidential health and care information is safeguarded securely and used appropriately. And I suppose I've come into post at what we can say are interesting times. And I'm very lucky to be taking on the mantle from such an amazing first National Data Guardian, Dame Fiona Caldicott. And something very important that happened last year was the addition of the 8th Caldecott principle, that, if you don't mind, I'll just touch on first, because I think it's so relevant to many of the questions we're having at the moment and discussions. And that is the new Caldecott Principle 8. It's that the importance to highlight the importance of informing people about how their information is going to be used. And I think that's hugely important. And it's sort of the basics of the principle is that there should be no surprises for patients and the public in how their health and care confidential information is used. And I think that sort of takes us quite nicely onto the first bit of your question, which is around challenges so far. And obviously the biggest thing to happen since I've been in role has been the stalled launch of the GP DPR program, the General Practice Data for Planning and Research program. And I think with hindsight, obviously I came in at a time when it was just being launched, but I think professionals and public hadn't been sufficiently engaged. And if you like, there were surprises for both GPs and the public about how data was going to be used. And I think it really underlined the importance of engaging people, but also that public engagement in how data is going to be used isn't a sort of one-off exercise. And as again, I think with the wisdom of hindsight, it may have been for those in government that they thought COVID had shown everybody the importance of digital and data, you know, that case was made. And although I think the public do get how important data has been and digital generally in the COVID response, that doesn't mean that people necessarily are going to agree with all proposed uses of their data in future. And I think it just underlines the importance of bringing the public, engaging the public authentically in all decisions about how data is going to be used. And I think the second part of your question, I think about should it be a national sharing guardian or such like. My recently published annual report, I've set out the principles for my priorities for next year, and one of them is to encourage better sharing of information for individual care. So I think it's incredibly important that we do take the opportunities of data use, just both for individual people's care, but also to really think about those amazing opportunities to improve care for all and make our systems more effective and efficient. But coming back to that 8th principle, people shouldn't be surprised about what we're going to do with their data. And I think the importance of safeguarding it securely is absolutely paramount for people to feel confident that it is going to be shared and used appropriately. So hopefully not too long an answer, but sort of touching on some of those questions that I think maybe might be relevant for some of the things that my colleagues here are going to be talking about later. Oh, I think you're just on mute there, yeah.
Thank you very much, Nicola. That's absolutely really clear answers, and the fact that you've produced an annual report already, and we need to put the link on the webinar so people can read it, and just really great to feel that you're in charge of the nation's confidentiality. I'm going to turn, in the light of your really, really interesting answers, to Faith Smith. So Faith Smith is one of our panelists. Faith is an amazing woman. I met Faith because she is the expert by experience carer on our mental health law committee at South London and Maudsley. I don't think I've ever met anybody who can so clearly summarize in a few sentences what the priorities are and what really matters to people. And I have been hugely honored by the fact that Faith has now been leading a pan-London expert by experience group for the development and the better design of urgent and emergency care services, including digitalisation. So for people on the call that on the thing that don't know, we've had the most amazing, I would say, leaps forward in London, in that the Metropolitan Police have agreed and have commissioned the digitalisation and the improved efficiency of the pathway for the use of Section 136. And Section 136 is when the police see someone in the street and they feel that they are distressed or disturbed in some way, and it warrants a detailed mental health assessment. However, as Faith has led her expert by experience work stream, what has become apparent is that the experiences for people from the BAME communities in relation to been picked up by the police in the absence of a mental health NHS service and been asked questions, and the thought about sharing care plans with advanced decisions has been kind of really, really concerning and worrying to people. Faith, do you want to give the panel maybe just summarize for them the 5 big issues that you and your focus groups have said are the big issues for people trying to access care, and what the 5 big problems are? And then some of those are about information, but some of them are about the ways in which digitalisation has been implemented.
Yes, thank you, Geraldine. Good afternoon, everyone. It's really great to be here and to, kind of be part of this debate. As Geraldine said, if you are from the BME population, your fear is of the police and what are they going to do. Even if you are in need, you're very, very reluctant to call the police. And actually, because of the experiences that people have had, the differences between how a person of colour is treated and how a person who is not of colour, it makes it really, really difficult to say, oh, yes, if you're in a mental health crisis, if there is a problem, call the police, because you feel that, are they going to listen to me? Are they going to help me? Are they going to hear me? Are they going to treat me in a way that is going to, potentially let me lose my life? So the things that we came up with, which are nothing new, I'm sure, to anyone who is listening, one of the things was, what has led to this crisis? What has happened? Has there been an issue of homelessness? Have you lost your job? What is it that has brought you to this level of crisis? And who have you tried to contact? Who has tried to help you? Is it family? Have you tried to call your GP? Have you tried to call your mental health practitioner or your mental health professional, who your care coordinator? And actually, once you then have called for help and have got to that crisis point, how are you then treated once you're there? Are you seen by a triage nurse and then they say, well, I'm going to call someone else, and you have to repeat your story, being re-traumatized 3-4 times, and by the end of it you just think, oh, I've had it, I've told you, can't you tell the next professional what the problem is? And then the issue of, as Geraldine touched on, of data sharing. Now, if you're somebody who is, I suppose they call it undocumented, or, if you haven't got settled status, or if you haven't got, a British passport, I've been to A&E with my son. I was born here, he was born here, and he was unwell, and it was a physical problem. And the first thing they said was, are you a British citizen? And I said, he's an ill British citizen. Now, not everyone would have the, you're worried, you're stressed. So if someone's in a mental health crisis, and the first thing, because you have a black skin or a dark skin, they're asking you, are you a British citizen? They're not saying, well, let's help you, let's see what the issue is, and we can do the admin stuff afterwards, that can be done along the way. Those are the kinds of issues that people are facing, and those are the reasons that people do not go for help in the first instance. And the other thing, the final thing is, who is it that knows you best? If I'm stopped on the street and the police say to me, we've had members of the public, you're acting in a way that we think is unsafe, how can I help you? They approach me. And if the first thing they say to me is, who knows you best? Do you have a care coordinator? Do you have a carer? Do you have a neighbour? So they can get the idea of, is this a reason why I'm acting like that? Have I had a recent trauma? Is there an issue? So those are the things that we should be looking at. Thank you very much.
Thank you very much, Faith. And Nicola, we may come back to you with Faith's comment about in a sense, what the mental health law reform is recommending, that people should have care plans with, relapse prevention, crisis response, and advanced decision, but they need to be shared. And the question is, how can we share those safely? So perhaps we could come back to you about that issue, because this is a big live issue in London at the moment, given that we know that 70% of people who present in crisis are already known to the system. But care plans with that kind of preventive element to them are sometimes not there, and people are very worried about sharing them. So perhaps we could come back to you about some of the thoughts about a solution-focused way of that. Now, the frustration about making the system work for people is something very familiar to my dear old friend, Dr. Hashim Reza. And I'm saying old because we're peers. Hashim, you've had a couple of passions that you have relentlessly not let go of for the entire 30 years I've known you. Tell us what you think we need to be doing to get the balance right between digital information and human rights in this going forward.
I don't know where to start, Geraldine. Thank you very much. As you hint, been trying to crack this problem since around 2007. And still, I don't think we have moved as many steps forward as we tend to slip backwards. Some of the challenges are technology, without any doubt. Some of the challenges are cultural. And some of that is probably in the give of regulatory bodies and our political masters, that they have created the culture they have created. So if I start from the most recent comment Faith has just made, who is entitled to care in an A&E setting? The NHS Charter would say everybody, irrespective of your nationality and everything. But the culture we have currently, the clinical teams providing care cannot be blamed if they are being required to check people's identity and passport and whatever. A technical solution can be very readily made available. In this health system, we have a unique identifier, NHS number, which is available for vast majority of patients at the point of care, that can automatically show whether people are entitled to care or not, without causing any further distress. And everything else that Faith says, it needs to be available. But the systems we have currently in use, they are rubbish in many ways. They have this information buried. Different systems configured differently does not enable staff to intuitively know where to search for this information. It should be visible on screen in the context of a care setting easily. All this can be done. And I think we can spend hours trying to unpick why it has not been done for so many hours, so many years rather. And just to add a personal perspective, like you, I grew up in a faraway country, strife-driven, and having very deep sense of trying to be pragmatic. And that is a very deep, very early impression. But I give a lot of credit to the training I did in quality management in a faraway country again, from which NHS, I would argue, has benefited a lot. It fundamentally argues that everything we do has got wastage in it, which can be as much as little as 20% and as much as 40%. Unless we have data, we do not know what we are wasting. And having reliable, credible data helps intelligent people, highly qualified and educated and trained, as analytical minds. It pinpoints us where the wastage is, how to eliminate it, and how to do the job better. That is what has driven me all these years. Thank you.
Thank you, Hashim. And as somebody who worked with Hashim on reducing the use of outpatient clinics by 40%, because having engaged clinicians and thinking about the purpose and the function and the efficiency, it became absolutely obvious that when you have a patient saying, "Doctor, you look so tired, and I'd have loved to talk to you last week when I was in crisis, but I couldn't get an appointment, and I'm seeing you this week and you've clearly got the waiting room full. Why do I need to keep coming to see you all the time?" That was kind of one of our first ventures together in actually just engaging your workforce and actually thinking about how we spend that most precious commodity, our time. So I'm going to turn now to Lia, our absolute, well, she's been a rising star for a long time, but Lia is taken on a whole new series of roles, all incredibly exciting. And I suppose I just pay tribute to Lia's involvement in helping us with the digitalisation of mental health pathways in urgent care across London. And my pet hate, which everybody knows, which is when people start saying, we're going to digitalize the paperwork, we're going to digitalize the mental health papers, as opposed to, we're going to use this digital as the most wonderful opportunity to digitalize what happens in the pathway, where the major amounts of wastage are, where people are having to enter data, duplicate times rather than free up time for clinical care. So Lia, I see you as kind of being one of the leaders that's really going to help us streamline the efficiencies of our pathways and also develop new training for many of our kind of digital and other fellows and staff so that they will actually digitalize in a way that is not just replicating the inefficiencies that we had on pieces of paper. Take us away. Give us a vision of the future as you see it now.
Thank you, Geraldine. Thank you very much for having me. It is just so lovely to hear everyone speak and just to be able to be part of this conversation. So, as Geraldine says, I've been working in digital for quite a long time, but actually the thing that drives me more than anything else is this word that's been used a couple of times, which is purpose. And Faith, thank you so much for sharing your story and your son's story, because for me, a lot of my work in digital is driven by the realization that the power dynamic is just not right. It is just not right. It is just not equal. And I see digitization of pathways, not forms, Geraldine, pathways, not forms, there's an opportunity there to redress that balance. And a lot of my original work was around patient-held records and people having access to care plans and what that could do for changing that power dynamic. And what I'm working on at the moment that Geraldine's referring to with the Pan London work is I work with a startup called, so I'm a consultant psychiatrist, but I do a lot of work in service design and digital service design. And I'm working with a company called Thalamus, who are digitizing the Mental Health Act. And what that means, they will tell you themselves that they thought it started out being forms and then very quickly became aware how complex the whole system is. And really, for me, it was about what was ethically at play here. And this is the reason I work with them, because they really take this seriously. This ethics by design piece is very important to them. And what that means is that we recognize that at the end of that form is a person whose life is in crisis. That is what is going on. And what can we do as a company or a system or a healthcare provider to provide the best care that we can? And that includes doing everything that we can to look at what we have, try and come up with new ways to make those systems simpler, safer, swifter is what we talk about internally in the company. And we think there's loads of ways to do that, actually. What people often don't recognize is that, again, I'm going to come back to that word purpose. A lot of the digital systems that we currently have, for example, the electronic patient records that doctors and nurses and healthcare professionals will use in hospitals, not really designed with end patient care in mind. They were not designed that way with that purpose. And that shows in how difficult they are to use and how they don't really always serve that purpose of providing the best care. And what you'll find is that there are companies like Thalamus and other startups that I've advised who have a very different way of looking. They're very mission driven. And it is a completely different set of sort of principles that you are looking at. You're not looking to provide a service to the bricks and mortar hospital, which is where electronic patient records started, frankly. You're actually looking at what is the end outcome and what is the user experience. And we talk a lot about user-centered design. That means looking at what every stakeholder in that pathway needs, from the clinician, the mental health act administrator, the social worker, very importantly, the patient and the relatives who are all involved in that care journey. And what are we trying to achieve? So the way we've taken that approach, what that means in practice with what we've done at Thalamus is I talk about ethics by design, ethics and safety by design. So my role is I'm a chief safety officer, which means that I have to think about how the company complies with the regulation. So there is this regulation for software. It's called DCB 129, if you want to know the numbers. And it has certain things that we have to do. But the traditional approach to that is very much once the thing has been developed, it's sort of a checkbox afterwards. And for me, having done digital and non-digital service design, I see the best systems that I've been involved with and the projects that I have been, most proud of are the ones where the clinical governance and the patient experience has been embedded up front from day one. We have been thinking about it every step along the way in every single design choice. So there's a quote from Cynthia Dwark from Microsoft that I quite like, and I was thinking of it, Faith, when you were talking, which is that design choices in algorithms embody value judgments and therefore bias the way systems operate. So we think that the technology is all dry and isn't really doing very much. But actually, the minute we are coding things in a particular way, making a particular design choice, we are embedding a value judgment. And that comes right down to influencing the fact that more people from Black and minority ethnic origin are going to be detained under the Mental Health Act. We know that's the truth. And we know that that's a consequence of the way the system is designed. So the way we're thinking about that in Thalamus is that we need to be aware of those things, and we need to be aware of every time we make a decision choice, and then I'm assessing what the clinical safety is around that. I'm thinking about that, and as a team we are thinking about that, and we very deliberately have a whole approach which we call lived experience by design. So we have Steve Gilbert, who's on our board, on our steering group, and we have a whole system of checking things off with all of these important stakeholders right from day one. We don't come back to it after we've had the brief from whoever is the customer. We do it up front. The minute we are starting to design that is we are checking that off. What does this mean? What does this really mean for patients? So there was a whole issue around video consultations, for example, with the Mental Health Act last year. And I wasn't involved in Thalamus at this particular point in time, but it is one of the reasons their approach was one of the reasons I did work with them, because there were very good reasons, there were really valid arguments from certain sectors as to why video consultations might be a helpful thing in mental health act assessments. But there was a whole other group of people, and Steve Gilbert was particularly influential in expressing this perspective, which was that at that point where somebody is so in crisis that they're needing to be detained, it should be their right that they are seen and assessed in person on a parity with a physical health crisis. And I think that's a hugely, hugely important perspective. And actually, it's been borne out. There's been a legal ruling around that actually video consultations should not be part of Mental Health Act assessments. And I to be honest, I saw the argument for the other side, because I could see that sometimes you might get better assessments, but I could also see that actually we shouldn't be biasing the way that system works by making it easy for video consultations and actually that leading to poorer care. And these are really, really important, vital things that we need to be thinking about, because we are making, as a company, we have to make these decisions very, very fast. We are doing them, the way software development works, you're on very fast sprints. So every single person, from every developer through to people in marketing, they know that this is the way we work. They know that we work by ethics by design, lived experience by design, and safety by design. And that means in every part of their job, they are thinking about those factors. Everybody gets introduced to Steve when they start, and everybody hears what his journey has been through the Mental Health Act system. And I don't think there's a replacement for that personally. And that, for me, that is the only way you change that power dynamic.
Thank you so much, Lia, and you've given me a great idea, because if I had my way, everybody who's starting a job at our service in SLAM would start by meeting Faith and just hearing it as it is and kind of taking things forward. So one of the things that you've all mentioned is kind of about almost waste in the system. So I know many of our trainees are listening, wanting to hear, so how should they be trained in digital? Is that a whole different educational stream? And I think that what you've all said in a different way is you start by thinking about the person's perspective, about the safety of the system, about the efficiency of the system, about the kind of, and you embed that so that actually it's flexible enough to be changed if that's what we need to do. And I think often people see the digital as being about how do you use the kit, not about actually the major innovation that it can achieve. So, Nicola, can I come back to you on that question that I was kind of asking you about the sharing of people who have been supported to make a care plan with an advanced decision? So the context of asking this is that we discovered through some much more, I would say, Android ways of doing it, in other words, big audit, that 70% of the people presenting to crisis systems are already known, particularly EDs. So your question is, so why are 70% of people coming back in crisis and if they had got a plan and it could be shared, would that make a difference? The other big number that has come out of this work, which was a huge surprise to everybody, was that there is a trust, at least one trust in the country, that has been able to work with their local police to reduce the use of Section 136 by 80% sustainably. And this trust has recently taken on a new area, and already within 8 months, they've reduced the use of Section 136 by the same method of working with police forces by 33%. So, and in each of those two instances that I've talked about, one of the things that's been put forward as the main evidence base for helping is to be able to share information so that people don't need to tell the story several times, to safely find a way to get the right permission and agreement with people about how their care plans with advanced decisions could be shared. And because that seems likely to become fairly mandated in the new mental health reform legislation. So as our national call to guardian, how could we make sure we do this well or safely? Or do you even agree with the premise, Nicola? Do give us some debate and challenge on this.
No, I mean, I think, with my clinician hat on, I'm still working as a consultant psychiatrist. I think it can be incredibly important to have the right information at the right time. And like Faith says, people shouldn't have to be repeating some of the most basic information. So I think the principle is absolutely right. I think Lia and Hashim would have more to say on the more technical knowledge of how these things work. But I think I'm very supportive of the principle, and also initiatives like the National Record Locator Service. That means that, if you're picked up by a paramedic team on the spine, it indicates, certainly phase one of the project was indicate that for example, you'd be under particular trust, and this is how to contact them to find out what the crisis plans are. So I think clinically it can be incredibly helpful for both a patient and professional that this evolves and develops. I think my one caveat would be to come back to Principle 8, and I think, as you said just then, Geraldine, it's about people being clear that is how that information is going to be used. And I think there is more we need to do to really think about people's expectations and understanding of how, coming back, I think, to some of what Lia was saying, how information flows across systems now and pathways, that it's no longer about bricks and mortar. So a crisis plan with a professional in one particular building will now potentially be, in future accessible across a whole system. And what does that mean in terms of what we tell people, how they can expect that it's only going to be accessed by people with legitimate reasons to access that? And I think there are sort of wider questions for us to really try and bottom out with people. And I'm keen to sort of look at this, and we've been talking about this as a team. If we think about systems now, care being provided as sort of through ICS systems, say, for example, do we understand enough about what people expect is reasonable in terms of levels of access and who might access information? So, for example, I may have a crisis plan for my mental health problem, but am I okay with the fact that if I go and see someone for a completely unrelated problem in a different organisation in my local system, what would I expect them to be able to see about my mental health history and crisis plans? What am I okay with? What have I been told about that? What would I expect in terms of who can access and how people can access things? So I think those sort of questions do need to be bottomed out a bit more. We need to do more work to understand what patients and the public are comfortable with.
It's always so reassuring to hear you talk, Nicola. I kind of feel like our information is safe in your hands, and I suspect I speak for everybody in the panel in saying, if you want any volunteers to help or socialize some of the questions and the things that need to be solved, I'm sure people would be really happy to kind of help out with that. So Jason Tan, who's the fantastic digital fellow who's kind of put this panel together. Thank you so much, Jason. One of the things he is very, very committed to is working out what do we do in this digital world for all the people who have no access to digital. whether that's patients or parts of the kind of the care provision system. Almost everything we do is dependent on having digital skills and access to digital kit. And we know that so many of our patients, particularly people with severe mental health problems, live in poverty, don't have recovery plans, live their lives with the expectation of a 20-year premature mortality, 2/3 due to physical ill health, not being treated, and 1/3 due to suicide. So how can what's the way forward? How do we as a country, and as kind of particularly as mental health world, need to think about digitally excluded people? Anybody want to have a go at answering that? Anybody come up with any solutions for that?
So Geraldine, we've been talking. So I have another role in NHSX. I'm a clinical advisor in the innovation team, and we've been talking about this quite a lot. And we have a whole program of funding around digital inclusion. And for me, it's very much recognizing that you have to have blended approaches. So on the healthcare side, for example, with the mental health at work, everybody will have access. All the clinicians in that system and the administrators have access to digital. And there are ways to make sure that the benefits of using those systems can be passed on to patients, irrespective of whether the patients have access to that or not. And there are definitely gains to be made. There are huge gains around releasing time to care, etc. For the types of service, so for example, we've been talking about this in relation to, for example, online therapy, and very contentious issue in the news around face-to-face GP appointments, etc. There needs to be a recognition that however the system is designed, it has to take account of people who want face-to-face and people who don't want it, who have access to digital technologies. And that has to be embedded from the start. I suspect we will get to a point, and this is a bit far off, where we're in a transition phase right now. And so the things that we're putting in place now have to take account that we are in that transition phase and appropriately don't all go for a completely digital type setup, which is only, we know it is exacerbating inequalities. And that's the worst outcome, really.
Anybody else on the panel want to comment?
If I could come in, I remember, Geraldine, many years ago, Sir Muir Gray led a workshop for NHS leadership training. And in that, he showed data of a survey done among mental health service users that quite a significant number of them would actually prefer to get a good quality telephone, smartphone out of their benefits money because it was so critically important for their autonomy. That would be their only window to the world, to the communication and staying in touch and all that. The point I wish to make from that is that some of these claims being made, they need to be data-driven. My personal view is that each of our communities are different, and within a community that I could be responsible for as a medical manager to provide service, there will be sub-communities within that. Each service needs to know where there are pockets of deprivation. And just to paraphrase what Lia has just said, technology exists where everybody can be supported. So people should have an ability that if they don't have the gadget or the internet connection of a good quality to get into whatever information about their next appointment or their test results or their most recent assessment outcome or show a care plan to somebody, they can telephone somebody and they can print it for them and they can hand over a printed copy or put it in mail for them. I don't think it is too difficult to create the solution. Solutions exist. We need to replicate them at scale. The real challenge is to know that we are not wasting money and we are creating solutions for the correct population and subsets of populations. And then signposting it very clearly that people feel empowered and enabled who to ask and what to ask.
So I think that's a great response, Hashim. And I suppose I would therefore ask, as a kind of a member of a board of a trust, how can you sit there as a board member? How can we know what the level of digital inclusion and exclusion in our local population is? Because as you rightly say, if the services are excellent, but they're only excellent for the people who can be included, that's kind of not the final measure of success. Do we have tools?
And perhaps at trust board level, knowing that in your boroughs, what is the existing data from internet providers, for example? Are there pockets of deprivation? Where are they? Can they tell you postcode by postcode, how many customers and citizens are, logged in? So I think there are ways in which data can be cleverly triangulated. But I need to go back to the question you put to Nicola, and Nicola provided a more kind of, sharing information between systems and different organizations. Your question about the frustration of citizens having to repeat their very traumatic experience endlessly actually sits much below the National Data Guardian. I see it repeatedly in my own service. Somebody pitches up in A&E, there is a local shared record, lots of people from Oxley services outside the mental health, they can have access, but do they know where to access to see their crisis contingency plan? It has been available for years now, probably for a decade now. Then within our own team, the A&E mental health liaison team will ask patient questions. They may then decide they need to admit it. Home treatment team will ask exactly the same questions again to come to a conclusion that yes, admission is justified. That is being called gatekeeping. So some of these bureaucratic layers that have been badly interpreted by our managers are actually creating more work for the clinical staff and lots of frustration for the patient. And part of that is because our systems are badly designed. Somebody has put it very nicely in recent CCIO, mental health chief informatic officers. They have a very active chat group. And somebody described it very nicely that our medical records are like a vast dump of Lego bricks. And everybody writing a note is like chucking a Lego brick in there. And somebody else has to go and rummage through and trying to locate which particular color brick, size brick, or shape brick they're looking for. Why can't the system be designed in a way that it gives me summarized information in the context, most recent cut of that information? And that is my starting point when I see the patient. And in a way, I being able to tell them, look, this is what I've been told. Is it correct? Have I missed something? And then build the story from there. Part of that is we are not training our, trainee doctors in that. I see endless cutting and pasting of inaccurate information in the records, showing me clearly that nobody bothered even to read it. And for me, the worst example, I'm happy to quote it, it is being recorded, a woman who was 7 months pregnant for 2 years. And this information recorded in her hospital admission, repeatedly being copied 2 years later, people not realizing that there are implications for prescribing in that. They're taking clinical decisions without even bothering to read the information. And it is so embarrassing in this day and age when information should be available and is becoming available to the patients. So lots of these problems are actually cultural. They're not just technology, they're not just technical solutions, but whole attitudes, how we create information, how we record it, do we think how it is going to get used next? And lots of the information is being created really for managerial or, regulatory oversight purposes, does not really add clinical value.
So you raise another really interesting issue, which I think is probably, there was a view at one point that we were so incredibly lucky to have a National Health Service. But the curse is we don't have a National Health Service because we have incredible variation between and within organizations as well as out with organizations. And I think when I look at wearing other hats, how have other industries transformed safety in a much more rapid time than I would argue we've been able to do in the health system? One of the things that they do is their whole process of policy making, of agreeing operating processes is never done without it being never finalized without it being tested over and over again with the people that have to use it and the kind of the end users, their customers or patients. So as you rightly say, I have seen so many initiatives where people say, well, we'll do this form really beautifully, and then we'll turn it into a PDF document and we'll send it. And then the question is, where is it sent to? Where can it be accessed? So I suppose my question to perhaps the digital entrepreneurial brains on this are, can digital help us achieve that transformation in safety and efficiency of pathways and care and efficiency of data entry so that it's accessible? Are there digital tools that can help us do that, provided we marry it up with doing things like having faith's expert by experience group relentlessly telling us what the priorities are? Or are we not there yet with that? Are our digital systems not quite skilled enough to do this? Is our artificial intelligence development not quite able to help us yet?
That one for me, Geraldine.
Sort of.
I absolutely think the answer is yes and no. From a perspective of Inside Thalamus, absolutely yes. I mean, this is why. So in the way features are developed, so if we're developing something new, we have a specific set of criteria that we need to look at before we start working on that feature, and that will include things that anybody who's worked in any kind of company setting will know. It's, what is the value to the client, how feasible is this, how usable is this? So we will look at usability. This is a big thing in software product, and we do not pay enough attention to it in healthcare products compared to other industries. How viable is something? And then we've added on 3 which are not so traditionally used, but is important to what we do. So we have the clinical safety part, which is where I come in with my safety by design approach, the information governance part, and the lived experience bit, which I've already told you a little bit about. So it is actually marrying up a few different things, some things about technology development in general and understanding the product pipeline and what you have to look at in terms of when you are developing the product. And then also packing into that structure what we know is important in our particular industry of healthcare. And because we are dealing with, sensitive patient information and data, that's why we have the information governance part as right up front in that part of the pathway. So I think it's actually not really about shiny tech. Actually, so many of these conversations I have is not really about the shiny tech. It is about the process and what you consider to be important in the process, and how early and you include that, and how agile and iterative you are with that. So I'm using another 2 sort of nice techie startup words, but they do have meaning. It's really about doing things rapidly and knowing that you can build something, identify what's wrong, quickly iterate and go round again. And you keep going round and round and round the circle. That's how we approach clinical safety. So we'll start developing something way before it goes out to testing. We are already evaluating what the likelihood is of something having some kind of patient safety impact. And then we're going around the loop again, and we'll go back to the developers, and we'll go back to the designers, and we'll go back and back and back. And this has absolutely come up in the 136 work. It's come up in other bits of work that we've done in Thalamus. And we have to do it fast because we are on these fast development cycles. And that is what you see in other industries, actually, because they have to. And it's sort of strange in a way that when we've got lives at stake, that we don't do that. We don't have that learning system up and running and moving fast so that we are identifying what's happening and we quickly are addressing it, making sure the learning is disseminated, and then moving on to the next. And we keep going. It's building, it's additive.
Thank you. I mean, to me, that's kind of the nirvana of a new model of change management. And I am very struck by the industries that actually do this constant iterative testing, sometimes using digital, but sometimes just using, they don't send a policy out, because I think my probably least preferred mode of action is where somebody says, we've written the policy, and you say, how many pages is it? And they say, it's only 120. But there is a summary on a page. And then you say, so how many staff actually will know how to use that policy? Because it's one of probably about 300. And people say, we sent out a blue light bulletin or a purple light bulletin or a purple newsletter or whatever. And my personal view is that that's very uncourageous leadership. because I think that's delegating to busy people who might not even have a clue about why you have policies in the first place, to actually be able to read something, assimilate it, translate it into how they're going to do it in their daily routine, and actually do it and kind of monitor it if they're implementing it. And that, to me, is what's different about the industries that have moved safety forward. And I suppose I would love to not end my period of life and my period of professionalism without seeing those kind of principles and practices applied within the mental health system.
And that's why the design approach is so important, Geraldine, because I think so often I've seen so many things just sort of built because someone says it needs to be built. And actually, it hasn't really been designed, and it hasn't been thought about, and a design thinking approach taken to that. And that is why we end up with rubbish, quite frankly, sometimes.
If I add to that, comment that I personally see two weakest links currently in our clinical information systems. Firstly is exactly what Lia pointed out, that machine, the policy Geraldine has referred to needs to be translated into protocols. So in good organizations, staff do not see the policy really, managers do, but staff need to be familiar with the protocol, how that policy gets translated into protocol, and protocol gets updated as things happen. In electronic system, those protocols and workflows related with that can be built theoretically. They do not exist in our current systems. That those workflows exist, individual staff, even if tired, distracted, or very early in a team, need not remember everything in their head, because machine will remember and will tell them what the next step needs to be. That is one weak link. But the biggest weak link is what is my basic passion, that the way we record information requires human processing. It cannot be easily coded. Therefore, it can never get linked to any rule-based algorithms that the new technology has. So while we keep on talking more and more of shiny, clever technical solutions, rule-based AI, algorithm, and whatever, we keep forgetting that unless the information is being fed in a way that lends the machine to process it in a coded form, all of that is going to be wasteful. And we will still be struggling with the same problems, having convinced ourselves as if we have created grand solutions. We need to go back to basics. All our clinical staff, doctors, nurses, pharmacists, everybody needs to be trained in a new paradigm, that they are not using pen and paper as the interface. Information has to be recorded in structured professional terms, staying close to patient narrative, but not just only the patient narrative, and move away from free text.
Nicola, what's your, you said to me you were going to be very quiet in this conversation, and I promised faithfully I wouldn't let you be very quiet. And Faith's also been unusually quiet, so I must be chairing badly is all I can say. But what's your take on this conversation? Does it have any resonance for your new role, as well as obviously your clinical role?
No, I completely agree with what Hashim's saying there about the challenges of how information's actually recorded. I'm feeling cautiously optimistic about that improving in future. I know, the data strategy for health and care, I think, tries to try and tackle that as a problem. And I'm aware that the Goldacre review is coming out soon, which I know is obviously research focused, but will make very similar points about the importance of data being held in ways that are actually going to be usable and useful for the system, rather than what we've got currently, which is kind of a digital version of a paper folder, coming back to that lovely bucket of Lego analogy from earlier. So I think there are technical challenges there, but I do think in the system there is an awareness of them and a commitment and to actually addressing them. How long it will take, I guess, is the fundamental question.
Right, Faith, you have been unusually quiet, and I love to hear your let me tell it as it is and what people need and what they need quickly. So what's your reflection on this conversation? Does it feel too far away from the reality of people's lives, or does it give you hope that actually you've got people really taking this seriously and trying to find new ways to improve things quicker? What's your take?
Thank you, Geraldine. My feelings are mixed, I have to say, because if we go back to the earlier part where we were saying about how do we include those who are digitally excluded. Now, if you think of somebody who is on a fixed income or who is on benefits and, you know, they're doing homeschooling and they're expected to keep their data up and they've also got to put a meal on the table, the chances are that their data is going to be the one thing that goes because they have to sustain life. And so even though everything is digital, your banking, your prescriptions, everything is online. But if you are someone who isn't online, it actually doesn't really help you. And I think that part of the solution to helping people who are not online, where all the libraries are closing, or the community centres are closing, those are the places that need to be reopened. They need to be staffed by peer supporters. So for argument's sake, if I'm a Rastafarian, I would like to have someone of my faith who is trained up, who can actually interpret, as it were, for me and say, look, this is what they mean by that. This is what they are asking you. And they can actually, if necessary, access, my prescriptions and say, right, I've done a prescription for you, or look, you've had an appointment. This is going to be next Tuesday. So that if the reasons you are digitally away is because you either cannot read or you have, sight problems or language problems, or it could be that you had a bad experience at school. And as far as you're concerned, I don't want to learn anything. I don't want to read anything. So that means then that you can't bid for new housing because it's all online. It means you can't know when your prescriptions are ready because it's all online. And if you then go to treatment online, if you're already in a state of crisis, you're already depressed, you're already paranoid, and then all of a sudden someone says, right, I'm going to put a camera and we're going to speak to you over, you're going to be even more, in a heightened state of anxiety. You're not going to want to engage. So I think that I'm not against technology because I think it is a good thing. But if my biggest worry with technology and going over to technology is that we are then at the mercy of the equipment, you're only as good as the person operating it and the equipment itself. Yesterday I was online and I was just about to speak and then it went off and it started saying not responding, and I was like, oh my goodness, what have I done? So I was trying to think, if I was in the middle of I'm unwell, I'm having a crisis and I'm trying to tell the doctor, then all of a sudden the equipment goes and you think, I understand that for a lot of people, they do want to do things online and it can be easier. But if you think of it in terms of under a medical crisis, how can you take someone's blood pressure online? You can't take someone's blood online. You can't have a tooth extracted online. So you can't, if it's someone with an eating disorder, they could sit there with 4 jumpers on and say, oh, yes, I've weighed and, I'm still the same, or I've put on another pound. And that person could be slowly declining. And we don't know because you've seen them online. And just one quick thing that I wanted to say as well. Now you've opened me up, Geraldine, you have to shut me down. To do with health and digital. Now, I've got a friend who her son is 19, like my youngest son, and he is diabetic, insulin dependent diabetic. Now he had to do blood sugars, as you all know, and they offered him to have like an implant thing, and that would monitor his blood sugars, and it's going to be all wonderful, all singing, all dancing. Now he had that implanted and we thought, oh, this is going to be good. But within a few weeks, he insisted on having it removed. And we couldn't work out why. We said, but, it's helping you. It's making it easier for you. But actually, sorry, am I going on too much, Geraldine? Did you want to come in?
No, it's not. It's just sadly, Faith, I knew I should have asked you earlier.
Oh, wow, we're out of time.
We have run out of time, but I mean...
Oh, sorry.
No, but aren't you amazing? One day I'm going to publish the wise words of Faith Smith, this kind of... Anytime you want grounded, anybody on this call, any one of our wonderful attendees or anyone on the panel, anytime you want to feel that you need to be grounded, just have a dose of faith and you can kind of come right back to basics. But can I just thank your panel? It's been absolutely fascinating discussion. I think we could have probably gone on for another hour and then we might have solved the entire world's problems. But thank you so much for taking time out of your really busy lives to come and share this. And I have to say, I, for one, feel enormously positive that we have, I do believe, the leaders now and the people who are interested and committed to grounded patient care, as well as actually using digital in the ways that will improve the system and make the lives of people trying to deliver good care, our staff, easier for the future. So thank you very much indeed. Take care, everyone. Thank you for listening. Bye.